And the case history is that he's a 25-year-old male who's normally fit and well, works in a medical gadgets firm. And he presented with a sort of 10-day history of sort of prodrome that culminated in fever. So I saw him, let's say, towards the end of 1 week, and in the middle of the week preceding it, he'd noticed that he'd gone to the dentist, and that evening he was feeling a bit feverish, a bit tired, generally unwell. He was in the middle of a house move, so this was terrible timing. He carried on going to work because he tested negative for COVID that week. In the evenings, he was effectively buying takeaways while packing and kind of moving things day by day before the weekend. And on Saturday and Sunday, he noticed he had a bit of a sore throat. He said he had some lumps in the neck that at the time were a bit tender, some issues swallowing kind of slightly acidic drinks like orange juice. And then come the Monday, he was too unwell to work. The fevers had carried on over the weekend. He'd had pretty horrible nights with sweats. And on the Monday, he felt absolutely horrendous. Even though he was negative for COVID, he didn't try to go into the office. His urine started getting darker over the sort of Monday to Wednesday. And he was getting some skin itching and a change in the color of his skin. I think on the Wednesday, he started vomiting and he sought medical attention, gone to the ED, some blood tests were taken. He was then sent home and then called back in on the Thursday because of those blood results. He denied any abdominal pain and denied any diarrhea. So based on a 25-year-old fit and well male with a 1 week history of sort of fever, lethargy and worsening jaundice, what kind of, I don't actually, I feel like, I hope it's not just loads of consultants on this call, but what are the key bits of the history that you'd want to kind of glean from the patient at this stage to help refine the diagnosis? So yeah, in terms of a travel history, he'd gone to Hungary about 3 months prior. His girlfriend that he lives with was from Hungary, so he'd visited her family. He lived in a small rural town.
When was that? When did you go to Hungary?
3 months prior.
3 months ago, okay.
Previous vaccination status, he didn't really recall any vaccines at the point of clerking specifically against, hepatitis. He denied any intravenous drug use, and he didn't have any contact with anybody with similar symptoms. As many sort of 25-year-old males during the week, he didn't drink very much, and on the weekend he drunk a bit more. I think at the time I sort of guesstimated sort of anything between 5 and 10 units a week. He didn't drink every week, but he drank some weeks. He had not had diarrhea, but he had had an episode of vomiting, which kind of prompted him to then seek help because he was getting progressively worse, and he kind of waited it out a week. And I think when he started becoming yellow, there would have been probably internal anxiety and also pressure from his partner and family, I guess, to seek medical help. Okay, so just going through that thing. So he'd gone to Hungary 3 to 4 months ago. In terms of sex, he'd had unprotected regular sex with a single female partner, no sex with other males, no recreational drug history. I asked about food, and particularly because he said he was moving house, and often people stop cooking in these sort of stressful situations, just before Christmas when moving house, like these life moments that everything's a bit chaotic. So he'd had lots of takeaways, a few kebabs, usually chicken. He denied any pork intake. I asked him about blood transfusions, either here or in Hungary, and he'd never had any. I've probably underestimated the alcohol intake, perhaps, but I think based on what he told me at the time, I wrote down 4 to 5 units. He didn't have a past medical history, never had any contact with medical, with any clinicians, but he was quite concerned about his jaundice because in his family history, his grandmother died following a severe bout of transfusion-related hepatitis when she was relatively young.
Died of the hepatitis rather than a transfusion reaction?
Yes. It was from the history he gave, it's like she developed severe hepatitis and liver failure following a blood transfusion that presumably was contaminated with something that was his. Yeah, he said it was hepatitis A. I guess I'm not sure whether that part was right or not.
He thought his grandmother died of hepatitis A.
That's what he thought.
Right.
On examination, he was frankly jaundiced. He didn't have a flap. His peripheries were warm. He had palpable cervical lymphadenopathy. He was going quite quick at 100 beats per minute, and he was an athletic chap. So this was, probably almost double what he normally runs at. It was regular. His heart sounds were normal. He was pyrexic in that little sort of cubicle that you have in the ED. He wasn't short of breath. He didn't have a palpable liver or palpable spleen. The abdomen was soft. The biochemistry that prompted the recall back to hospital was as follows. So white cells weren't markedly elevated, but the lymphocytes were mildly up. The platelets were low, so he was thrombocytopenic with a platelet count of 84. His ALT was greater than 1,000. Bilirubin was greater than 100. His ferritin was 1,500. He'd swabbed negative for COVID. His clotting wasn't deranged, and his albumin, although I've not written it here, was in the normal range. His chest X-ray and ECG were unremarkable. When he was called back into hospital, they'd arranged an ultrasound of the liver, which showed mild splenomegaly, but nothing else of note. The liver and the contours appeared normal. The vessels appeared patent. So based on the above information, what would be your, I guess, top 3 most likely diagnoses as to what's driving?
Do you want to go back to the numbers, and then everyone can type in what they think? So we've got our first entry at viral hepatitis.
Yeah.
Not specifying which virus, but someone will do that in a minute. Thank you, TV. Okay, so we're going for Hep A. And there are other viruses, of course. And thank you, Alex has put in Epstein-Barr.
Hep A, brilliant.
And then Hep E. So we're going for viral hepatitis. And I'm sure that I don't think any students here, but just this is the sort of thing that is really quite important for their exams, because in exams, only one answer can be right. And that... and everyone seems to be going for that one answer, viral hepatitis.
So the patient was admitted into hospital for diagnosis, because what happened was he sort of came in on that Thursday, and the blood test that we repeated on the day showed a worsening bilirubin, worsening ALT. The gastro team were unhappy for him to be discharged at the time because of these numbers, until we had a clear diagnosis of what was going on. We were actually coming into the Christmas weekend perhaps as well. And so there was a bit of anxiety around follow-up in that period.
Although if it is hepatitis A, then being at home is the best place, really. Yeah.
So he was admitted, and he spent at least 48 hours while I was working on the AMU. And I think I saw this patient with you, Prof. Miran, and we were discussing the possible causes. And I was thinking, because the bloods for some reason took a while to come back. And you could get fevers with either Hep A or Hep B, I guess, if you're symptomatic. The symptoms of these infections are very much the immune response to the infection of the liver. But yeah, so I saw him with you, and you were quite convinced, because at the time we saw him then had developed some diarrhea. The side room, and you were thinking this is probably hepatitis A, and then I just sort of revealed my own ignorance by thinking, but he hasn't really been anywhere in the past couple of months apart from Hungary before that. Surely that's unlikely. And then you were saying that hepatitis A, you acquire these things in takeaways locally in London. It's really frequent. Many of the cases aren't associated with a travel history necessarily. And so then I've sort of done a bit of reading around the hepatitis viruses, and thought I'd just give a quick 5 minutes on kind of how we can catch these things in the UK in a manner that is relevant for us to think about when we're seeing patients in the ED. So sort of the hepatitis viruses themselves, not including the herpes viruses. I feel like the chronic infections are really sort of well covered throughout training. We constantly send off bloodborne viral screens. And so hepatitis C, hepatitis B, and Delta, these are all sorts of chronic infections that we often screen for in patients that we screen for HIV. They can present with an acute hepatitis, but by and large, we know them as things that can cause cirrhosis and hepatocellular carcinoma. I think half of the world's burden of liver cancer is associated with HBV. I think 2 billion people are serologically positive for exposure to HBV. So it's very common. And at least in starting work in London, there have been quite a few patients, particularly from South America, that have been HBV positive, HCV positive. Now, hepatitis A and E, at least when I left medical school, I thought of very much as things that you acquire when you travel to countries with poor sanitation. Hepatitis E in particular, a big problem if you're also pregnant and female, because then you're at risk of very severe liver injury, and I think the fetus is also at risk in that situation. But after my foundation school in the east of England, I came across quite a few cases of Hep E virus in Cambridge, and I was really baffled as to how these people who had virtually no travel history were coming back and testing positive for hepatitis E virus. And then hepatitis E virus is actually 4 different genotypes, 2 of which are transmitted fecal-orally across most of the developing world, and so particularly sort of Africa, Asia, South America. And there are 2 other genotypes that are found across the developing world. They're endemic. They're endemic in the UK, and they're found in deers, pigs, rabbits, things that we will eat if we're having a very boring, just a sausage and mash dinner, a barbecue on the beach, or even if you're going for a slightly fancier, medium rare cooked venison steak in a fancy West London restaurant. So all of these are RNA viruses, which would be in keeping with their kind of acute hepatitis picture. Usually the RNA viruses, they give rise to sorts of hit and run infections. RNA is itself quite unstable. So if you're working with it in a lab, you really have to clean everything, because our breath, our skin, our clothes, they all carry enzymes that break this stuff down. Hepatitis C is, one of the only exceptions to that rule that can cause a chronic infection is an RNA virus. And they're non-enveloped, which means they're resistant. You can't just kind of alcohol gel them. They survive well in sewage and in water for long periods of time. Another non-enveloped virus that really exemplifies this is like the foot and mouth virus that kind of was blown by wind from France to Britain in the 70s. So they're really resistant that they can travel. So starting with just focusing on these 2, hepatitis E and hepatitis A, looking at the epidemiology of Hep A infections over the past 10 years in the UK, you can see there's a really steady number of reports, quite low and relatively rare, apart from in 2017, where there was suddenly a spike, specifically among males between the ages of 15 and 45, let's say. And this outbreak was particularly focused within the males who have sex with males community, and exemplifies how you don't actually have to travel in order to catch hepatitis A at all. Looking in regards to the travel history, roughly half of the cases in the sort of age bracket of our patients have no travel history at all. And this was the data from England and Wales 2019. So in red are the positive, like lab reported cases associated with travel history. The blue is, red is no travel history, and green is unknown. These histories, probably thanks to really intensive probing questioning from whoever took the history from the patient, they walked into the front door, usually really kind of exemplify this. So travel history is absolutely not something to rule out any of these infections. And you can acquire these because it's fecal-orally spread. You can catch these in a takeaway. If somebody is carrying the virus themselves and shedding it in their stool and hasn't washed their hands properly, it can end up in your food. I think in 2019, there was a hotel in London where somebody who was preparing food was found to be Hep A positive, and there was a mass epidemiological hunt to find everybody who'd been eating in that restaurant, and all that information is available on the Public Health England website. They engage in some prophylactic vaccination to large members of the public. So triaging these patients, the incubation period, 2 to 3 months. So even if they've been traveling many months ago, and infectious hepatitis is in, they have to go into a side room. they'll continue to shed the virus from about 2 weeks before symptom onset to roughly 1 week after the onset of jaundice. And again, any viral hepatitis needs to be in a side room until it's diagnosed and sent home, basically. Really great, because it would be a disaster to transmit this across a ward. Looking at hepatitis E, you can see that Hep E is everywhere. It's very much not a travel-associated infection. It's just different genotypes are in different places. So the fecal-orally spread variants are most often found in the developing world, and the zoonotic variants are found in the developed world. This isn't anything to do with the number of sort of viruses. This is just, is the genotype present in the country or not? It's not quantifying, it's qualitative, I guess. And so looking at how hepatitis E virus contaminates our food chain, there was quite an interesting paper that was reported in one of these PDFs that Public Health England produced, where the authors had actually swabbed pork and the pork processing surfaces across the entire food supply chain. And this is unfortunately a table, but I'll just talk through it. This is a porcine adenovirus, which you'd expect to find in pig poo. So this is looking for fecal contamination. And this is human adenovirus, which you might find in human stool, as this will be a negative control. And you can see that the negative control is negative across all their samples, so they haven't contaminated it with their own feces. But when you take a look at the feces from the slaughterhouse, 98% of the samples that were collected from 40 different pigs were positive for the adenovirus, 13% were positive for hepatitis E. And they kind of did this along from the slaughterhouse to the processing point, to even the points of sale. And they actually went to 2 major supermarket chains, and there aren't many, that's basically half of what's available, and 1 butcher. And hopefully not the butcher here at Barron's Court, because that looked really nice. And I'm looking forward to like good weather to pass by there and pick up something for lunch one day. But they took 75 sausages and randomly sampled them. And on those 75 sausages, 10% had hepatitis E virus RNA within those sausages. And a separate study that I couldn't actually open up for some reason was a screening of just large numbers of abattoirs across the country, or at least the southeast of England. And 95% of the pigs that were slaughtered were seropositive. So this is completely prevalent out in the wild and across our farms. And 1 in 100 had a really high viral load at the time of death. And a key difference between Hep E that's acquired from, pig meat in our barbecues and the fecal orally spread is that the pig meat in our barbecues tends to be less symptomatic, and you have a higher degree of asymptomatic carriage of the strains 3 and 4 that are prevalent, say, in the UK or America. And the problem with that is that if you're asymptomatic and carrying the virus, you can then donate blood as a good Samaritan and a good citizen, and you'll be completely none the wiser that you're carrying virions of hepatitis E. And there was a Lancet study here in the UK in 2014 where 225,000 blood donations were screened for hepatitis E, and viruses were found in 0.04% of them. 62 contaminated products were actually administered to 60 recipients, of which about a third had, some degree of immunosuppression, be it they had autoimmune disease or multi-organ transplant recipients. And this paper goes into quite a lot of depth into the outcomes of all of those. And lots of those, had actually developed the infection. They had to have their immunosuppression tweaked. They had to be given some antivirals. And you can see that we probably give more red cells and everything else, but only 25% of the red blood cell products that were administered manifested an infection. But things like fresh frozen plasma and pooled granulocytes, things that you'd particularly give on liver wards, which would be a real disaster, transmitting Hep E virus to somebody with cirrhosis when they're having their acidic drain put in. So as a result of these studies and a bunch of others around Europe demonstrating that transfusion-associated Hep E existed and was problematic, I think we've now implemented screening for this in 2017. But this seems so recent for a virus that I think was first described in the 80s. And looking at the prevalence of infections in the UK every year, I thought this was quite striking that in 2007 so now there's been quite a marked increase in the number of PCRs reporting this. Now I guess that will be partly due to increased awareness about this, particularly since the big paper in 2014, but it exists and should be kept in everyone's mind. So it's great that we brought it up. And so whenever thinking about lack of travel and infectious hepatitis, think about barbecues, think about pork, think about blood transfusions, and don't forget the travel as well. So in our case, this is what came back from the liver screen. The immunoglobulins were normal. The ANA was surprisingly actually positive. The autoimmune hepatitis antibodies were all negative. He was hepatitis A virus IgG positive. And when I asked him about this in sort of follow-up telephone calls, because we were then monitoring him remotely when he eventually got home, he then told me that he traveled to Thailand many years ago and received a bunch of vaccines ahead of that trip. And so I guess he may have been vaccinated against Hep A in that context. In terms of Hep B, Hep C, they were negative, but EBV, IgG, and IgM were positive. He had a striking EBV viral load, and he was actually monospot positive as well. So he was diagnosed with EBV hepatitis, discharged home, and then monitored remotely. After the 2-3 day admission, he was discharged. The ALT peaked at 1,400, bilirubin at 127, and they progressively declined in the run up to Christmas. So I guess the learning point is never forget the herpes viruses in the acute liver screens. So sometimes just because they're not called hepatitis, they sometimes get forgotten. I know that Cerner has a really great acute liver screen function that you can immediately just select the things that you want from a large list of possible options. If you're suspecting EBV, the monospot test is actually comes up under the infection mononucleosis screen, and I couldn't find it when I first plugged it in, so we had to do it a bit later on. But I think that's much faster to turn around as far as investigation goes. It's definitely faster than the PCR. Mm-hmm. Any febrile jaundice, put them in a side room. And I was just hoping to ask anybody whether an ANA titer of 1 in 160 is of any significance, or is this something that just people accumulate over the course of their lives, perhaps exacerbated during acute viral infection and then settles?
Really clear, thank you. That was excellent and very educational. And so the prize, somebody put EBV in the chat.
Yeah.
Goes to Alex Nobar.